My name is Jessica Levin, and I'm the Chief Program Officer at Let's Talk Menopause. And we are a national nonprofit changing the conversation about menopause so women get the information they need and the healthcare they deserve. Our menopause talks are central to our education efforts, and we have, I think now 30 of them on our website. So they are just an incredible source of information. And just a few housekeeping items. We have disabled the chat. So if you have questions, you can ask them in our Slido question and answers. And you can look at the chat for links that we will post, relevant links to this conversation. So please ask your questions in Slido questions and answers. And there will be a brief survey at the end, which we ask you to complete so that we can continue to improve our offerings for you. Okay, so I wanted to introduce Dr. Mary Jane Minkin, and there really aren't adequate words to really capture the greatness of Dr. Minkin and also what she means for Let's Talk Menopause, because she has, from the very beginning, been an incredible friend and supporter of Let's Talk Menopause. And we have also learned a lot from her. And so we just wanted to thank you and thank you for joining us today. Dr. Minkin is a leader in women's health education, both inside and outside of the medical community, and she has a special focus on menopause. And she has taught at Yale University School of Medicine for over 45 years and is a clinical professor in its OBGYN department. She is also a North American Menopause Society certified menopause clinician, which is now called the Menopause Society. And she's co-director of the Sexuality, Intimacy, and Menopause for Cancer Survivors program at Smilo Cancer Hospital. I think that's how you pronounce it. I'm not done. There's more. She's also an author, co-author of numerous articles and books, including A Woman's Guide to Menopause and Perimenopause, which for decades, that topic, she has been out in front educating women and doctors. I want to do a special push for her website. It's madameovary.org, and in particular, her podcasts. Many of them are relevant to the topic today, and it is an incredible resource for everyone to use in addition to our own website. So thank you, Dr. Minkin, for joining us.
Jessica, thank you.
So I wanted to articulate our two goals for today. Many of you will remember that last week, Dr. Rachel Rubin discussed local vaginal estrogen with the audience, last month, and we will put the link to that in our chat. We are today doing systemic menopause hormone therapy, and we want to differentiate that from local vaginal therapy so everybody really understands the difference, which is a very important topic. And so Dr. Minkin will talk a lot more about that. We also want, we have another goal, is the question of how do we all move away from fear-based medicine when it comes to, especially when it comes to midlife and menopause, because a lot of what drives our decision-making today is anxiety about what treatments we use and don't use, and what risks we worry about in conjunction with the treatments. And I fall victim to that as much as anybody. And I think Dr. Minkin is the perfect person to help us navigate that topic, because she neither dismisses the fears women has nor denies them, but really talks with women about them. And so we're going to discuss that more today also. So I'm going to start with, I want you to give an overview of systemic menopause hormone therapy. And I'm asking you first to just start by differentiating it from local vaginal therapy. Tell us what the difference is, what the differences are.
Sure, absolutely. So basically, I can distill exactly what Jessica said. I'm old and I talk a lot. So anyway, that's why I'm here. And I want to thank Jessica, I want to thank Donna and all the Let's Talk Menopause, my friends, for inviting me here and to talk about this most important subject that there is. And indeed, one of the things that's good about differentiating vaginal therapy, local therapy from systemic therapy actually ties into a campaign that we've been doing here at Let's Talk Menopause, which is basically to try to get the FDA to remove from its package inserts a warning about estrogen therapy from vaginal estrogen, which is sort of crazy for it to be there in the first place because the amount of estrogen that gets absorbed from therapy in the vagina and the vulvar area is pretty close to zero. I won't say it's zero, but it's pretty close. And so really, but the FDA has yet to do that. So ladies, fill in your postcards and whatever to try to campaign against, to realize, make people realize that there's a significant difference. Systemic therapy is basically a way to get estrogen into the bloodstream. That's really what we're talking about. And we can get into the bloodstream through patches, through topical gels, through oral pills, through, now there is one vaginal ring that actually delivers systemic levels, blood levels. The other vaginal ring just does local therapy, basically. And so, and again, I feel badly to have to make such a differentiation here because systemic therapy didn't used to have a bad name. In the old days, estrogen was good for us. And it still is, and I guess I should, well, you people voluntarily signed up for this so you can listen to my horrible singing voice. I always go back to that old James Bond song, you know, nobody does it better. And the key thing is that if, and we've learned it, and the nice thing about menopause these days, I'm going back and forth on a few thoughts here, but menopause has become very chic in the last almost 2 years to talk about as far as what hormone therapy can do for women who are suffering from menopause and all the bad things that menopause can do to women as far as symptomatology. And we can talk about hot flashes and night sweats and sleep disruption and achiness and all that other fabulous stuff that goes along with menopause, which many of you, I'm sure, unfortunately, are dealing with. And estrogen helps with all of that stuff. It really does. And women got scared of it.
I'm going to actually, before you talk about the fear, I want you just to talk a little more about the symptoms that systemic hormone therapy treats. Just so there are some that people are very familiar with and others they may be less familiar with. So I want to start there before we go to what happened in the field.
Absolutely, absolutely. And the other thing that I'm going to differentiate is official indications for hormone
Yes,
therapy,
please.
systemic hormone therapy. And I know that we're going to have a link to the Menopause Society's 2022 estrogen therapy guidelines and stuff like that. And the major official indications for hormone therapy, for estrogen therapy, are relief of moderate to severe vasomotor symptoms. That's a fancy way of saying hot flashes, okay, which also impact on sleep significantly. The other official indication is for therapy for vaginal symptoms when there are other things at play, like the systemic symptoms. And systemic hormone therapy will help vaginal symptoms. Vaginal therapy will not help systemic symptoms. So that's something just we need to clarify, again, because of the very low amount that's absorbed. Now, systemic therapy gets to the vagina, so it will relieve vaginal symptoms. Now, just one little sidebar there, about 20% of women will need a little booster, even if they're on systemic therapy, because we use fairly low doses these days, that we need to give them a little booster for the vagina to keep them totally comfortable. About 80% of women are just fine with what they're taking systemically. Their vaginal symptoms will be under good control. And the other thing, by the way, when I mention vaginal symptoms, I should be including bladder symptoms, because the official terminology for the old vulvovaginal atrophy, which was vaginal dryness, is now GSM, or genitourinary syndrome of menopause, because a lot of bladder stuff goes with the vaginal stuff too. And the other official indication is prevention of osteoporosis. Okay, those are the official Menopause Society guidelines. However, there are a number of symptoms which are not official guidelines saying use estrogen for this, but estrogen definitely helps. Okay, now things that estrogen can help: sleep, a very important thing. achiness, women who experience things like arthritic symptoms, never had arthritis before, a lot of the stuff may well be alleviated by estrogen, even if it's not an official guideline. Things like mood, the answer is, again, not an official guideline, but also can help mood. We do know, for example, that women who have a history of previous depressive episodes, when they go through menopause, unfortunately have a higher chance of getting a recurrence, exacerbation of their depression. Estrogen can be very helpful along those lines. So there are a whole bunch of other ancillary things. Some of the things that we know happen, it's not an official guideline. It's not only vaginal dryness, but skin dryness everywhere. Most women experience dry skin. Some women can experience hair loss that can be associated with it. Again, not an official indication, but some women find it helpful.
Mary
So
Jane,
a lot of symptoms.
I'm gonna just cut you off occasionally just to intervene with some questions that I think people will have while you're talking, if that's okay. So can you clarify why all those symptoms that menopause hormone therapy treats, but the guidelines really focus on relatively few?
Mhm.
Why is that?
Well, one of the problems is, and this has always been a problem with menopausal research, is are these things related to the loss of estrogen, okay, or are they symptoms that we are getting as we're getting older? And that's indeed one of the stigmata of that as menopause carries. It means we're getting older. Most of us go through menopause as we're getting older. Although some people can become menopausal at 35, so that does happen as well. And those are very young ladies. But the issue is sometimes it's hard to differentiate. Do we gain weight as we get older? Yes. Do we gain weight as we go through menopause? Is menopause the cause? This is actually an area of controversy. As we get older, our skin can get drier. Is it menopause? Is it aging? There are a number of things that there's overlap between getting older and loss of estrogen itself. Certainly things like the hot flashes seem to be something that's much more related to the lack of estrogen than us getting older, if that
Okay,
makes sense.
and just take a step back for a second. When you say menopause hormone therapy,
Mhm.
talk about what that means. We have a number of questions about estrogen and progesterone. So if you could take people through, when you say hormone therapy, what are you talking about?
Absolutely. The issue is it's estrogen if you have just a uterus. If you do not have a uterus, okay. If you have a uterus in place, and this is from discoveries back in the 60s. And well, I'm going to backtrack even further. Menopausal hormone therapy has been available since about 1942. Okay, so estrogen is not a brand new substance here that we've used medically. And indeed, for many, many years, we just used estrogen alone. That was it. Menopause hormone therapy was estrogen therapy. And then in the 1960s, started emerging some data that women who had a uterus in place, had not had hysterectomies, we were seeing more uterine cancer developing in the women who were taking estrogen. Now, it wasn't a huge epidemic by any means, but it was a number of people. And then folks realized, oh, well, we can help prevent that if we just basically introduce another ovarian hormone, which is progesterone, okay, which is what we make when we have our menstrual cycles, leading to either getting pregnant or not getting pregnant and cleaning out the lining of the uterus. So we started using progesterone, and so that became the sort of combination in somebody who has a uterus in place.
Yes. And so I have a question here. When you're on estrogen and progesterone together, are,
Mhm.
if you could talk a little more about, someone is saying they have increased do they get increased migraines on those? And is it from the progesterone or the estrogen? If you could just talk about that.
I'll cut that to a very brief answer because we could spend the next hour talking about
Yeah.
migraines and menopause. Most of the time, the side effects of that women experience are more related to progesterones or progestins than the estrogen itself.
Yeah.
Okay. So indeed, and there are also synthetic progestins, and then there are naturally occurring progesterone, okay. And basically, and that was actually only introduced to the market 20 some years ago. The first things that were used to control the lining of the uterus were actually synthetic progestins, basically the same stuff that's in birth control pills. Okay, much lower doses, but same stuff. And so anyway, that many of the side effects women experience are actually related to some of the progesterone, some of the progestins. Micronized natural progesterone tends to have less side effects, but the progestins seem to be the ones. So if somebody's having migraines on therapy, it can be tricky to deal with that. And sometimes it's an estrogen dose, but oftentimes it's fiddling around with the progestin that can take care of that.
And someone actually asked another progesterone question, then we'll go back to estrogen. This just around they have severe bloating with the progesterone, and is it okay to take progesterone vaginally instead when you're taking systemic estrogen?
The answer is yes, you can. There are basically, I don't know of anybody using synthetic progestins vaginally. I don't know if there's any data on that, to be honest. There actually is a special preparation that is made for vaginal administration, and that's something that the infertility people use. Okay. And that's called crinone vaginal gel, which the infertility people use regularly. We have borrowed it from them, and you can use that. There are some folks who will actually use micronized natural progesterone vaginally, and I say if it works, it's fine, but that's something you want to discuss with your provider. But crinone vaginal gel is made especially for the vagina.
And it prevents the lining of the uterus from growing.
Yes.
Okay.
Yes.
So you mentioned osteoporosis, and it's been approved for the prevention of osteoporosis. Would you recommend, if someone doesn't have other menopause symptoms, to go on hormone therapy for the prevention of osteoporosis?
That's a very interesting question. And the answer is, to me, it's a relative thing. Okay. The key thing is that you need very little estrogen to prevent osteoporosis. Okay. You don't need very much at all. So is it an official thing that you're supposed to use it? Officially, the use is in somebody who has another indication for it. But do some people use it just for prevention? The answer is yes, they do. And you don't need very much to do so.
So there's a lot of discussion right now, Dr. Minkin, about estrogen preventing dementia, estrogen preventing heart disease. What is your thinking right now about using menopause hormone therapy as a prevention strategy?
Well, this is a highly controversial topic, and let's talk about what we have definitive data for and what we don't. No question, we have definitive data that estrogen helps prevent osteoporosis. Okay, so anybody who disagrees with that is wrong. Okay, period. End of sentence. They're wrong. Okay. The next one, as far as hierarchical things to discuss, does estrogen help prevent heart disease? Okay. And what's all of this has stemmed from is the USPFTF task force, whatever abbreviations they use, basically came up with and has reiterated their statement a couple of times saying that estrogen does not help prevent heart disease. Okay. We don't have the data for it. Okay. And this is indeed, I don't know if we want to go into how the WHI got started. Maybe
We're going to go in a second. We're going to go into that.
Okay.
Yes.
Well, we could tie into that right now because the WHI, the Women's Health Initiative study, was basically a study done. And if I can go into it, it'll take me a couple of minutes, but I think it'll be make
That's
things
right. Right now, yes, please.
more understandable. And this was a study, and of course I make a joke on this because the study, the nurses' health study was the first study that got going, a big study. And I always say it's probably the best study that's ever come out of Harvard. I'm a Yale person, so what can I say? Anyway, but this was a nurses' health study, and they basically studied 121,000 women as they went through life. And nurses are the most fabulous people doing studies because they will fill out any form you give them. They will give you blood. They will give you urine. They're wonderful people, and they got a lot of data. Okay. And the data that they saw as these women just went through life, this was not a study, this was just an observational thing. It wasn't a prospective randomized double-blind thing. They saw that the women who took estrogen had much less heart disease. That's how this whole thing got started. And this was corrected for age, family history, obesity, cigarettes, all this stuff. It seemed that just the use of estrogen really seemed to make a difference for these women. So what happened is, and of course, one thing to remember, let's go back to the 1980s. Okay, ancient history there for you youngsters listening in. These women couldn't take statins because statins really hadn't been invented for women. It was something, can't do it if it's not available. So this was really a breakthrough saying, oh, gee, this estrogen helps prevent heart disease. Maybe we should all be taking estrogen for heart disease. And what happened is that the company that manufactured the estrogen went to the FDA and said, can we say it helps prevent heart disease? Look at this study. And they said, well, not so fast, because we really don't have a double-blind, prospective, randomized double-blind trial. And maybe there's what we call a healthy user effect. Maybe the women who take estrogen are intrinsically healthier than the women who don't for some reason. And so they said, so let's conduct a prospective randomized double-blind trial. And that's how the WHI was born. Okay. And so what happened is that the WHI got started, and when it got preemptively stopped in 2002, one of the arms, there were two arms of the WHI, and that you have to remember also. There was an arm of women who had hysterectomies, and those women didn't have to take progestin with their estrogen, okay? But the women who had a uterus had to take progestin with their estrogen to help prevent cancer of the lining of the uterus. Okay, that's fine. And the estrogen plus progestin arm was stopped early for two reasons, primarily because they saw this quote unquote increased risk of breast cancer. So that's how we're going to tie into the breast cancer question. Okay. The women who took estrogen alone never showed an increased risk of breast cancer. Keep that in mind. So if you've had a hysterectomy, don't listen to the next couple of minutes. It's useless to you. But basically, the study showed a very, very slight increased risk of breast cancer in the women who took the estrogen plus progestin. However, it also did not show protection against heart disease. Okay. And people are very confused, like, why is this? With the WHI started to investigate this question, and look, this study doesn't even show protection against heart disease. Okay. Well, a couple of things to note, that the women in the Nurses' Health Study were ladies going through life, going through menopause and stuff like that. And when did they take their estrogen? When they started getting hot flashes and feeling miserable. That's when they took their estrogen. Whereas the ladies in the WHI study were not, and the average age of menopause in the US is 51, so many of these women were probably taking it earlier in their perimenopausal years, as many of you are noting, perimenopausal women who are taking some estrogen. So the women in the WHI study were 63 years old on average. They were not 50 years old or 48 years old. They were 63 years old, many years post-menopause. Okay. And so people started saying, well, gee, maybe it's because they had this gap time between the actual cessation of their periods and the initiation of estrogen therapy. Okay. But one thing we do know is if we have a woman, I'm jumping forward again a little bit, if we have a woman who's extremely young when she goes through menopause, and people haven't, don't get scared, ladies, if you're not there yet. Some 35-year-olds will go through menopause. About 1% of women in between the ages of 35 and 40, or before the age of 40, let's put it this way, 1% of women will be menopausal. Okay. And we know if those youngsters who go through menopause are not given estrogen, we know they have a very high increased risk of heart disease. No question about that. Very high increased risk of heart disease. They also have very high increased risk of dementia, which we'll talk about in a minute. But if you have a woman who's much older, say a dozen years after menopause, it didn't seem that the estrogen helped prevent heart disease. So I'll talk about a study that was done to investigate that. Okay, it was a very nice.
Dr. Minkin, I'm going to stop you for 1 second.
Sure.
Okay, because I want to just reiterate, because what Dr. Minkin is talking about, my question I was going to ask her is, why is there so much fear about systemic hormone therapy? And to understand that, it is very important to understand this study that Dr. Minkin is discussing, the Women's Health Initiative study that was stopped in 2002. Mm-hmm. Before you go on, can you talk to people about the number of women on hormone therapy pre-2002 and post-2002?
It fell dramatically. It's now about, from the peak use of estrogen in the United States, we're now down to below 8, it's an 85% reduction. Less than 15% of women are who would have taken estrogen previously are taking it. So it's a huge reduction in number of women taking it. And why is that? It's a very easy answer. It's called fear of breast cancer. And I've got data to prove it. Okay. And the data that I'd like to quote, if I may quote this data, okay, it was a study done. I think to me, this is the best example out there. Best example. The North American Menopause Society, at that point, as it was called, commissioned the Gallup organization in 1995. This is way before the WHI stuff comes out. And they asked women 44 to 65, my ladies, okay, I'm metaphorically here, women that I take care of, between the ages of 44 and 65, what is the #1 killer of American women, and what % of American women die from this disease? Simple question. Okay. And I ask this of my medical students. I ask this of basically any talk I give to professionals, so I can try to say, listen, this is what your patients are talking about, are scared of. You have to discuss this with your patients. Okay. Do you know what the answer is? Well, breast cancer came out as the %1 killer of American women. And do you know what percentage they said of what percentage of women they thought died from breast cancer? 40%. Okay. Now, some people say when I start talking about this, oh, I'm making fun of breast cancer. Hell no, I run a breast cancer clinic, for God's sakes. I mean, I work at Smilo Cancer Institute. But 40% of us do not die from breast cancer. It's a horrible disease, but about 4% of us die from heart disease. I mean, about 4% of us die from breast cancer. About 45% of us die from heart disease, from coronary artery disease. So anyway, and they repeated the study. The Gallup folks repeated the study a few years later, got exactly the same data. Okay. So American women are terrified of breast cancer.
Okay, and why? So briefly, if you can explain why, what about the publicity when the 2002 study stopped created so much fear in women?
They heard the word increased risk of breast cancer, okay, and they were like, I'm not taking this, I'm done. And believe me, they flushed their estrogen down the toilet because these were my patients. That's what they told me they did with it. And my standard line is I wouldn't want to be a fish in the United States on the next day. But they all flushed their estrogen down the toilet. And what was even more pathetic is including my patients who had hysterectomies, who, in the group, the WHI part 2, women who had hysterectomies who didn't take progestin, never had an increased risk, ever.
So, Dr. Minkin, I know that in that study, they showed something like 8 more breast cancers out of 10,000 women, a data point like that. So what I want you to do is just talk about what the study did show briefly, and then what has happened since then to basically try to broaden the story for women.
Sure. So basically, for those of you who have a statistics background, okay, the data that the WHI printed on, and it was, by the way, the embargoed news came out on July 9th. The article came out on July 17th. Anyway, 2002. And if you look at the numbers, for those of you who have a statistical background, the number wasn't even statistically significant. The confidence interval touched 1. So for those of you who know that, take a look at the study. Basically, the increased risk was extremely small, is what it boils down to. And the number that Jessica was reciting there is that the baseline group, the number of women developing breast cancer after 5, and by the way, the increased risk was only shown after 5 years of therapy. So you say, oh, I'm dying, I want to take some estrogen, but I'm so scared of breast cancer. You take it for 2 years, no data shows any increased risk after 2 years. I can tell you that. This is after 5 years. But the number that Jessica was referring to is that the overall group basically showed a risk of developing breast cancer, being diagnosed with breast cancer, of about 38 per 10,000 women per year. Okay. Now, in the group of women who didn't take estrogen plus progestin, the number was 30. Okay. In the women who did take estrogen plus progestin, the number was 38 per 10,000 women per year. And basically the terminology here is what's called attributable risk. What can you say might have been due to the estrogen plus progestin? That was 8 per 10,000 women per year. Okay. That's what they saw as the attributable risk. Now, for somebody who says to me, oh my God, that's too high a number, I can't even think about it. Well, you know what I say to that person? Let me find you something else. I don't want you sitting and worrying about this. But somebody says, I have to feel awful, like the way I feel, for a number of 8 per 10,000 women per year. You're crazy. Okay, let's talk something. Now, a couple of things that I do want to mention right now, okay, is that the study was only done on 1 estrogen and 1 progestin, a synthetic progestin. Okay. We now have a couple of products out, okay, which seem in studies, now it's not as big a study as a prospective randomized double-blind trial like we had here, but there's a good amount of data from Europe showing that micronized natural progesterone with estrogen does not seem to increase the risk of breast cancer. Okay.
That
And
a
we
different is micronized iodine, is that a significantly different type of progesterone?
Well, it does the same thing to the lining of your uterus, and that's what you're using it for.
Yeah.
However, it basically is a little different structure. Okay. It protects the lining of the uterus just the same, but it's a little different structure. It's basically the same progesterone as our ovaries make, okay, to protect our uterus. And indeed, and it's available at your corner drugstore. And you do not have to go to a compounding pharmacy to get micronized natural progesterone. You can get it at CVS, Walgreens, Duane Reade, any place you want. So anyway, so it doesn't have to be compounded. And basically, all of the estrogen, for example, that's in patches and gels, okay, and oral, you can get this orally, is 17 beta estradiol, which is exactly the same estrogen as our ovaries make. So you don't have to go to a compounding pharmacy to get 17 beta estradiol. It is available at your corner pharmacy. So that's just an aside. So anyway, but basically, so the studies on micronized natural progesterone do not show an increased risk of breast cancer. And there is another product that's out, which is very interesting, which is actually a drug that is very similar to tamoxifen, which we all know is used to help prevent and treat breast cancer, combined with estrogen to protect the lining of the uterus. It's the first drug other than progesterones that have been progestins, which have been shown to protect the lining of the uterus. So we have lots of stuff out there that if you're really terrified of breast cancer, say, okay, we got other stuff. Don't worry.
Yeah, okay. So
now, let me qualify one thing. I don't want somebody taking this out of context here, okay? That there is no prospective randomized double-blind trial showing this, okay? We have smaller datas there, okay? But we do not, as I said, we don't have as big a study as the WHI.
So it's interesting because also there talk about what other information we have had since 2002 on the link or the lack of a link between hormones and breast cancer, like in terms of survival, like or mortality.
Well, we do have some follow-up studies of the WHI that we also have. And then if you look at the long-term outcomes based on the WHI participants back from, the years previously, that there was no increased risk of breast cancer mortality in there in the 18-year follow-up. Mm-hmm.
And why, Dr. Minkin, is this remains 22 years later the driving fear of women and doctors about menopause hormone therapy?
Well, I think it's just, publicity and the persistence that breast cancer is a scary subject for many women. Understandably, it's a terrible disease. But we have many ways to mitigate risk, and the risk itself is pretty darn small, even from the original study.
So another question I have though is, in terms of Let's Talk Menopause, and you're part of this effort, this campaign to get the box warning off of local vaginal estrogen. And this is the same box warning that is on systemic hormone.
It is. It is.
And it scares, both of them scare women.
They scare women. And what happens is, and I tell all of my students of any nature, whatever age they are, that when you prescribe vaginal estrogen, do tell the patient what's on the boxed warning when they're going to pick it up at the pharmacy. I always tell them that, okay? And it takes another minute or two, okay, but I do it. And then what happens is the patient goes home, the partner takes a look at the box of estrogen vaginal cream that she's got and reads the boxed warning and says, honey, it's not worth us having sex for you to die. And that's literally what I've heard from many of my patients. They go home, the partner reads it, done, they throw it in the garbage.
And so one of the things that we're trying to do, along with you and a whole group of doctors and researchers and women's health leaders, is to advocate for the removal of that boxed warning on vaginal estrogen.
Absolutely.
That box warning will remain on systemic estrogen. And how do you Yes or no? And how do you talk to your patients about that then?
It probably will. And I go through this. I tell you, I'm telling all you all, and I tell this to all my patients. And that's part of the reason I did my website, my Madam Ovary website. I've got a lot of podcasts and written information there on just these issues. And I want people to know the data and let them make their own decisions. Exactly.
And so someone has, this is a really interesting question. 49 disruptive hot flashes on vaginal estrogen, and her gynecologist wants her to try black cohosh before moving on to hormone therapy. Now, the interesting thing is, in our first menopause talk, when we asked you about supplements, this was like 3 years ago, you mentioned black cohosh.
Did absolutely. And I still talk about it.
So
Okay.
talk a little more about that for hot flashes, but also the overall mentality of that doctor saying, do not do this till you try everything else, basically.
Well, there are some people who only like, au natural stuff and, herbal things and stuff. And I want to work with them. I want to work with what they're comfortable with. Okay. And black cohosh, a pure form of black cohosh, does have good data showing reduction of hot flashes. Now, the North American Menopause Society, the Menopause Society, does not endorse basically any herbal products. Okay. And part of the problem is these products are are poorly regulated, okay, and so they're very non-uniform. Now in Germany, they tend to and the one of the brands that I like a lot is something called Remifemin. Yes, I endorse a brand because
Can you slow down and spell that so people can write that down?
Remifemin. And I do consult for the company. I have to tell you that. And the reason I consult for the company is the stuff works. And it's the #1 product used in German breast cancer centers. I'm a breast cancer doc, as a gynecologist. I am not an oncologist. I am not an oncologist. But, I take care of their hot flashes. And that's the #1 product used in Germany. And it does seem to help. There's data. A problem is if I give people dirt, I mean, I'm sitting in my office, if I go outside, dig up some dirt, and I come back and tell you it's black cohosh in this country, and nobody's probably going to stop me. But in Germany, they'll throw you in jail. So this is a problem. So if I give you a purified product, and now there are some companies in the United States that do offer purified products and stuff like that, and well-regulated products. I don't want to say that none of the companies do in the United States. There are a number that do, but unfortunately, you got to know which ones those are. And so you got to be careful. Okay. Now, there are people who really want herbal stuff, and that's fine. And the other thing to remember is any herb, if you take enough of it, well, not any herb, but many herbs, if you take enough of it, are toxic. And I started off my life as an internal medicine intern. Okay. And the best overdoses, no, I'm saying this facetiously, but the best overdoses that we saw were digitalis overdoses in those days. People who took too much digitalis, which is a heart medicine regularly prescribed, but and it comes from the foxglove plant. It's directly from the foxglove plant. You take enough digitalis, you'll die. And we used to see some very interesting arrhythmias, funny rhythms of the heart coming in with digitalis. So many herbs in too much of a level will do you in too. So that's something else to remember. But the key thing is that the other thing you have to remember about doctors or providers, any provider or practitioner, is the fact that in July 9th, 2002, menopause education stopped in the United States. Okay. So if you have any doctor of yours who's trained, or nurse practitioner or anybody else, PA, who's trained after July 2002, it's likely they got next to none as far as menopause education. And it really is only in the last 2 years that menopause has become a much more legitimate thing to talk about, which is great. So providers, and again, some of the old folks are retiring. It's a terrible thing, but they're retiring. So the people who learned about menopause really many of them aren't there practicing. So you have to be careful going to somebody who might have learned something. That's important to do also.
So on our website, you can find a certified menopause provider and find a provider. I have one more question, Dr. Minkin, right now before we turn to our audience, more of our audience questions. So, we wanted to move away from think about how we can move away from fear-based medicine. And this is something we're grappling with at Let's Talk Menopause, because you have there are people continuing to point out that there are risks for certain women of taking menopause hormone therapy. And there are doctors who are reinforcing that. And there are doctors who basically are concerned about prescribing hormone therapy. And there are other doctors with a very broad audience, trying to move the pendulum in the other direction by saying safe and effective. And so, we want to understand how you make room for nuance without not passing completely over nuance and, ensuring women who are suffering are not too afraid to get the care they need. And if you could just talk for a minute about that and how you navigate that with your patients.
Sure. Well, I try to give them data. I mean, I try to be a data-driven person, okay? And so, for example, when it comes to risks and when it comes to benefits, I try to be data-driven. I mean, to go back to one of your questions a couple of questions ago was as far as health indications for estrogen, okay? We know, and basically just to jump back to the WHI study, we know that women who initiate estrogen therapy later on in life, okay, are not going to get protection of their heart. And they may at some point in their life show some hazards from taking estrogen way too late, okay? And I feel terrible when I say this. And we're now getting people coming in their 70s, not that 70 is old, but people who have been on estrogen for 20 some years. And they're like, can I take estrogen to help prevent heart disease? And the answer is no, it's not going to prevent heart disease. Could it possibly exacerbate things? It depends on their basic status, but it's not going to help them. And it might hurt. So it's not a panacea for everybody. The other thing about dementia stuff, and this is where there's a lot of false information promulgated, unfortunately, is there really is, and I love estrogen, guys. I love estrogen, but I cannot in good conscience say that estrogen given to somebody who's reaches menopause in her 50s, something like that, is going to get protection from Alzheimer's disease if she takes estrogen. We just don't have the data, okay? And we do have data if somebody who's much older, and the WHI study did show this. They had what's called the WIM study, and they had women who were between the ages of 65 and 79 enrolling on estrogen to see if it prevented dementia. And indeed, if anything, it increased the risk, okay? So if you're between 65 and 79, and you've not taken estrogen, I certainly would not push you to take estrogen for prevention of Alzheimer's. We have no data on that showing it's good, and there is some data out there showing it's bad. So do not take it for those indications. But if you are a person who's 35, and the other thing about the WHI, sorry, I have to go back to these things, but one of the things that really annoyed me about the WHI, more than annoyed me, I was quite irate, is that unfortunately there are some young women who go through menopause. We got 36, 38-year-olds going through menopause, and they heard the WHI and they dumped their estrogen in the toilets too. And I really begged people, I literally got on my knees to beg some of my patients who were very young, please, this study doesn't pertain to you. Not one woman in the WHI was under 50.
Right,
Okay.
right.
That, the average age was 63. These are not you. You need your estrogen. We have very good data that somebody who's 38 needs to take estrogen if she goes through menopause. It's not good for her heart. It's not good for her brain. Okay.
So,
and they didn't specify that.
Yeah, so now they're clearer on that.
Yes.
Yes. So I want to turn to a number of questions now. We greatly appreciate that overview. This is a very important and quick question. You mentioned a very low dose is needed for osteoporosis prevention. When you say very low dose, give us a sense of what that dose is.
Okay, well, for example, one product was actually trialed for older women, okay, as far as prevention. And indeed, this was called the Ultra study, and it came out about 25 years ago, something like that, 25 years ago. And the dose that they used was basically a 0.014 patch. Now, the lowest dose patch of estrogen we prescribe these days is a 0.025, which I refer to as baby dose estrogen. It's good. It works for a lot of people. I don't want to, say it's bad. But the dose in this patch was 0.014. And it showed that it did work. So you really don't need very much. So say if you're looking at oral estrogen, 0.5 milligrams of 17-beta estradiol, 0.3 of conjugated estrogens, a 0.025 patch. Those are probably okay doses for prevention of osteoporosis.
And if you're down to 0.02, if you're down to the lowest dose, you still need to add the progesterone?
The answer is yes.
Yes.
Yes, but less frequently.
Someone is just asking, what is the name of the company product that Dr. Minkin just mentioned? I think they're talking about the black cohosh? Is that the black cohosh that someone's talking about? I
Black
guess,
cohosh, black cohosh was Remifemin that I was talking about. But the patch was a 0.025 patch. Actually, the point in the study was a 0.014 patch, and that was called Menistar. And I think it's still available.
okay.
MENOSTAR was the
Okay.
0.014 patch.
And one person asked, is HRT still contraindicated for factor V lead-in heterozygous patients?
That's a really good question. Folks, there are some funky clotting genes out there. Unfortunately, very prevalent in people from Northern European extraction. And they are increased risk with an increased risk of blood clots. And we do know that oral estrogen does increase the risk of blood clotting, even in somebody who doesn't have a funky gene. Funky genes make it a little higher. We do have data from Europe, okay, which shows that transdermal estrogens patches do not increase the risk of clotting, even in somebody who has, even as you described, a factor V Leiden heterozygote. However, many people are still anxious about it, but there is data from Europe showing it does not increase the risk of clotting. Not a huge amount of data, but it does. There is some data.
Is the patch go-to? I mean, is your patch the go-to now for you unless people get skin irritation or stuff? How do you think of the patch versus oral?
It's basically depending on what my patient, you have to individualize. And the other thing that I have to say is that when I teach my residents and students, and I try to encourage everybody to become a menopause doc because it's such a wonderful thing. But the problem is people will never make money as in menopause doc. You will never get rich because there's too much stuff to go through. There's really too much stuff to discuss. And so there's no one go-to for all. You have to really individualize to that patient. So do I use oral estrogen? Sure, I use oral estrogens. Do I use patches? Yeah, of course. And again, you have to individualize to what the patient's needs are. For example, somebody who does get migraines, okay, can take estrogen, okay, if they get for like birth control pills, if she gets migraines with aura, no, you don't want to give her birth control pills. But in somebody who doesn't have auras and she has migraines, a lot of people have hormonally mediated migraines and they'll do well with some estrogen. Those people we tend to use patches on. In general, because people who have migraines tend to do better with a very, very flat level. They don't like a lot of variations as far as what we call pharmacokinetics. And so they tend to do better with a patch. I mean, there's all sorts of different things. If you have somebody who gets irritated by Band-Aids, I'd rather not give her a patch.
So I want to go back to this issue of duration of hormones, because someone asked, is there a time after which systemic hormone therapy is no longer viable? And someone else asked, my severe symptoms started immediately after stopping systemic hormones and ceased when I resumed. That's why I was on the quote unquote pill until I was 63. So both those questions are, you address there are some risks if you start it when you're older, like a certain number of years after. But what about you're on it? This is asking, does it poop out in terms of its effectiveness?
No.
Talk a little about that. And what if you go off it and you have symptoms again that are problematic?
Well, that's a really excellent question, and thank you for the interesting question. As far as do I tell anybody to go off? Basically, no. So I said, you're happy, I'm happy, it's fine. That some people, and there is no official guideline to say you can be on it X number of years. Okay. I must confess, there is a tiny amount of data, okay, of women who've been on it for over 20 years, just estrogen. People have had hysterectomies, that 20 years of estrogen may increase your risk of breast cancer slightly. Okay. And to be fair, and I always kid around, me and Fox News, we're fair and balanced here, Anyway, so I want to be fair and balanced. Isn't that their motto, I think? Anyway, that there are some people who will, that really should probably go off at some point. A couple of things about it, but in general, if somebody's happy, I in general keep them on it if they want to stay on it. First of all, one bit of data we have is you can taper estrogen off. There's no data to show that tapering is better than cold turkeying as far as less symptomatology. Most menopause practitioners say always taper, but the data actually doesn't support it, but I still say taper it. The other thing that I always tell people, if they're going to fiddle around with estrogen dosages or stopping estrogen, please do not do it in the Northern Hemisphere in the months of July or August. because if you get hot flashes, they're going to be worse hot flashes. So please do this in like November. That's a good time to do it, not in the hot months. And again, I taper, I see where the people get symptomatic. Now, one thing that I will do, okay, and this gets back to the person, I think there was a question, the person who was on the birth control pill until she was 63. If
Well,
I
I think
heard
she
the
was
question
on,
right.
I think she
What
was
was she
on
on?
systemic
Hormone.
hormones
She's
and
on
then
hormone therapy.
went
Okay.
on the pill after that.
She went on because I wasn't sure about from the question. The key thing is if you are on birth control pills, which are very valuable things, by the way, to control perimenopause symptoms. Perimenopause is very nicely, if you can take birth control pills. Again, if you're somebody that gets migraines with aura, please don't do it. If you're somebody who has uncontrolled hypertension, please don't do it. And if you're a smoker, please do not take birth control pills over the age of 40 or 30, over the age of 35, actually. Please don't do it. But if somebody is on birth control pills for control of perimenopause, which can be a very valuable thing, the question becomes, when do you stop to figure out if you're fully menopausal? Okay. And the reason that I do that, because the question comes up as a corollary, I think, of what was asked there, is why stop birth control pills? And why go to something else? Birth control pills have a lot more hormones than estrogen replacement therapy, far higher doses, okay? So what I will do if somebody's on control for their perimenopausal symptoms, they're on birth control pills, and I just had a patient this morning that I was discussing this with, that indeed we stop the pill when she gets to whatever age we decide that she decides, and we go off the pill and see how she is. And if she's off the pill and we know she's menopausal, we can switch her to a much lower dose hormone replacement therapy, and she'll live happily ever after.
Okay, so we're going to do what people call a lightning round to get through the rest of the questions, okay? Because I want to make sure just that everyone gets to benefit from your extraordinary knowledge even a little bit. So we have someone 4 months on menopause hormone therapy started, age 69, 0.025 patch, 100 milligram vaginal progesterone, still some nights with hot flashes. And she wants to have 0 hot flashes. So she's asking, is this realistic? And if so, what should she do?
Okay, first of all, she should talk to her practitioner. That's the most important thing, and see what she or he might advise. My concern is that she started though at age 69. See, that's why lightning rounds are tough, because I got to ask questions.
Yes.
We don't start too many people at 69, so it's a little gray area as far as what's going on. And the other thing that I have to mention is other things can cause hot flashes besides menopause. Okay, so if the hot flashes are better, okay, substantially better, but not perfect, you can talk to your prescriber about whether you want to go up a little bit and see if that helps. It's certainly a reasonable thing to discuss. Okay. There are alternatives one can use as a buffer to sort of help along those lines. And the one other thing I just want to mention for everybody, as much as I love estrogen, okay, that I take care of a lot of cancer survivors, and there's one drug out on the market and a couple other drugs that are being in development for hot flashes, which are very good for hot flashes, but are not estrogen. So those are other options that we have and will have more of over the coming years. So I just want to mention that there are things that are reasonably effective, which are not estrogen. So they're out there. Can she play with a dose of estrogen? Yeah, but you want to do that under supervision of her particular prescriber.
So I want you to clarify one thing, because someone asked about the risks of going on hormone therapy after 60. It's also within 10 years of
last menstrual period, correct. So if somebody went through menopause at age 59, at age 68, she's still going to be within 10 years of her last menstrual period, yes.
And then you consider that safe?
I don't have absolutes. I think it's a reasonable thing. You want to take, her medical conditions, in advice as well.
And so there's a question, a few people, they want to know that, she answered this question about taking progesterone vaginally. You said that was okay to take progesterone vaginally?
As long as you're getting some absorption from it,
That
and
is a situation you would do blood tests.
you can. Yeah, okay.
And someone's asking about the progesterone. Is it okay to increase progesterone while not increasing an estrogen patch? And she's asking because it seems like having insomnia and progesterone helps with, is it true that progesterone helps with insomnia?
Natural progesterone, synthetic progestins do not in general. Natural progesterone does. And have I increased progesterone doses for women with insomnia? Yes, I have.
And you feel comfortable with that up to a certain dose? Is it up to a certain dose you feel comfortable?
Well, I mean, our typical dose for somebody who's on, say, a 0.025 or 0.05 patch would be 100 milligrams.
Yeah.
We go up to 200 regularly in people on 0.1 doses of patches. I don't know that I would go too much higher than 200.
Yep. And
General.
what are your thoughts on the productive factors of estrogen in relation to insulin resistance? Is there a correlation? This is a great question, by
An
the way.
excellent question. In the WHI, and I do quote the WHI occasionally for good data, there is some very nice data that shows that if you take estrogen, you have a lower chance of going from prediabetes to diabetes, for example. And even your most ardent WHI lover has to admit it, it's in the WHI. It's like, as Will Rogers, the great Will Rogers used to say, I read it in the papers. So anyway, it's there. So yes, there is good data showing that estrogen helps take care of insulin resistance. And it certainly is something that's worth talking about. Absolutely.
So this is one more, I think I have time for one more question. I'm actually going to ask this question. My mother had estrogen receptor positive breast cancer, never took hormones, had no genetic factors. Well, the question just disappeared, but her question was obviously, is she a candidate then for
The
hormone
answer
therapy?
is absolutely yes. Okay. The answer is that I'm going to go back to the WHI. Okay. For he himself has said it. They themselves have said it, that indeed that a family history of breast cancer does not preclude the use of systemic estrogen for menopause therapy. And many people are concerned about it being sort of like an analogy of throwing gasoline onto the fire.
Yes, correct.
And the answer is it is not. And WHI data shows it is not like throwing gasoline into the fire. Having a family history will increase your risk of breast cancer. Okay. But it's not like, oh my God, if I take estrogen, it's going to escalate that risk.
And have there been studies on that?
Yes, WHI. The WHI
Okay.
knows it. Yes.
Okay. So I'm sorry we did not get to absolutely every question. We wanted to thank you enormously, Mary Jane, for being here, being always here for us. We want to point everyone back to our website, letstalkmenopause.org and madameovary.org. We want to thank you, Dr. Minkin, so much. And we know our audience, benefits from listening to as much as we always do. So you can sign off. Thank you so much. We just put up the poll to complete the survey. We ask everyone to do that. And this talk is part of our monthly menopause talk series. You can see all our prior ones on our website under programs. And please spread the word to others. This is a conversation we all need to be having. We will stay on to make sure everyone has time to fill out the survey. And thank you again, Dr. Minkin.
Thank you very much, Jessica. Thank you, Donna. Thanks everybody from Let's Talk Menopause. And I wish everybody a very healthy and happy holiday season.
Thank you.